Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Pranam Ben. He's founder and CEO at The Garage, and Brittany Sachdeva. She's COO at Cibolo Health. Welcome.
Thank you.
Welcome, John. Thank you for having us on your interview.
Yeah, we've had Pranam on before. Excited to have Brittany here. But for those who don't know you, Pranam, why don't you start us off? Tell us about yourself in The Garage.
Sure. John, I distinctly remember our last sit down. It was a lot of fun, and I'm hoping this one will be even better. So I'm Pranam Ben, founder and CEO of The Garage. We are a population health management platform company, been in business for about 14 years, absolutely committed to helping providers transform to value-based care across all communities, and excited to be here.
Awesome. Brittany, how about yourself and Cibolo Health?
Yeah, thanks for having us. Brittany Sachdeva, I'm the Chief Operating Officer at Cibolo. Cibolo Health, we're building high-value networks for independent rural providers across the country. Today, we have over 200 hospitals and $20 billion in net patient revenue that we help to support and manage. And really, our goal is to aggregate economies of scale so that our members can participate in value-based care in a way that they would likely be unable to do independently.
Awesome. So Pranam, let's start off there. What do many people not understand about what's happening in rural healthcare today?
I think it's very interesting, John, because there's two misconceptions, right? One is there's some natural assumptions about the fact that what works in urban healthcare will work in rural healthcare. Nothing could be more opposite of that assumption. I think rural healthcare deal with very unique realities, very unique challenges that you don't see in mainstream urban healthcare, whether it is access, affordability, transportation, awareness, literacy, social factors. There's so many unique challenges to rural communities that, it would be extremely naive to assume that what we do when we serve urban populations will work in rural communities. That's number one. The other side of that same thought process is that what you also see is how resilient these communities are. The fact that for decades, these providers that Brittany and Cibolo support have been very gritty, committed, built longitudinal relationships, and served their communities against all these odds speaks to the strong fabric that they have built within their communities, right? So one is the fact that they face unique challenges, and two is, in spite of that, they have served their communities for the last few decades. So I think these two aspects of rural healthcare are never discussed enough and never appreciated enough, and there needs to be a spotlight on that and help them get ready for what's to come.
Interesting. Brittany, what would you add? And also let's talk about some of the keys to ensuring things like access and workforce challenges and even just sustainability of rural health in general.
Yeah, I agree with everything that Pranam said. The challenges in rural healthcare are specific to rural healthcare. It is, I've spent over 20 years in healthcare, and I've worked, obviously doing the work that I do today for these small rural independents, but then have worked at huge systems with tons of infrastructure. And so I think that I have a direct sort of point of reference that collaborates exactly what Pranam is saying. A lot of our facilities that we help to support through our high value networks, they are the largest employer in their community. They are what keep the community afloat and financially viable. And so it is an extreme burden, but and a profound responsibility that they are so proud to be able to offer. Yeah. So I think some challenges around access and specific to rural, particularly as it relates to value-based care, and part of why Pranam and Cibolo Health have the relationship that we do is we want to participate in value-based care in rural. Over the last several years, as value-based care has really evolved, one of the barriers to entry is just scale. You need enough scale in order to perform it, and we need rural relevant contracts, which we've got some really strong, solid peer relationships that are paving the way for that. What we know is that as we try and access these value-based care contracts, we've got limited scale facility by facility, and our facilities are really solid at primary care. They go to church with these people. They see them in the grocery store. They're very, very good at primary care and that management. When you get into the total cost of care, about 50 to 65% of the spend, the total cost of care for our attributed patients in these rural facilities, is happening outside of our walls.
Wow.
And so there is recognition of our members that we have to do a better job of helping to manage the total cost of care through cost and quality metrics, not just access and service. So when we're looking at how we manage our patients and the access to the services that they get, sometimes just to get to the closest facility might be an hour drive, might be 90-minute drive. And that's before we've even started to think about how does cost and quality of these big referral partners come into the mix or play.
Interesting. Yeah, I mean, you just highlighted a lot of the challenges, especially with value-based care. If they're not even going through your doors, but you're responsible for that, and then just even knowing that they got the care so that you could help treat it. That's fascinating. How are you looking at the Rural Health Transformation Fund, the $50 billion, that's available to rural health, and how is that impacting rural health? And also what are the opportunities there for kind of transformation that you could embrace from this infusion of cash?
Yeah, so we did not obviously have rural health transformation. There was no line of sight that was going to happen. When we started Cibolo about 5 years ago, I would say with anything, there are challenges and there's opportunity. So I would start by saying that we've never dealt with this, and when I say we, I mean the whole ecosystem. So as I've been working with our various HHS leaders in our states, I mean, thank you. But I can't imagine what their jobs are like right now.
Sure.
Every single state got funds for year one, which the pro is absolutely, rural healthcare has never been on the map like it is today. How this $50 billion over the span of 5 years transforms healthcare, I don't think any of us have the clear vision into what that looks like. But what I do know is that this positions rural healthcare in a light where they can at least catch up from an infrastructure standpoint, so that they've got some footing to sustain. They can think differently. They can think creatively. They can do things that would be impossible without this additional infusion of money.
Interesting. Yeah, go ahead, Pranam.
We're all excited about the RHD funds, and Cibolo is a primary, their entire primary focus is on ensuring that their members benefit from the strategic investment, the dollars that come with it. The way I look at it is, one, it's a lifeline. And I say that not because of the current challenges in rural communities which we reflected on, but I also think about what's coming with the Big Beautiful Act. If you really think about it, and if we just look at it from a number standpoint, right? $50 billion of infusion, but potentially $900 billion to $1 trillion in Medicaid cuts. So you can't make sense of this, and both of them happening on the same period of the next 5 years, right?
Yep,
You can't say that one will balance the other because it doesn't.
it doesn't.
If you look at it differently and say that if you take politics out of it, right, and say that the Big Beautiful Act is to ensure that we can calibrate the needs of these communities, and RHT gives them a very focused opportunity to get ready for that. So if you look at it strategically, and if these organizations don't be smart about it, use the funds to prepare their communities for what's to come with the Big Beautiful Act, right? I think there's going to be very difficult terrain coming up, right? So thinking about creating that infrastructure, creating that virtualization of care, automating workflows using AI, reskilling workforce to ensure that they can leverage digital technologies and platforms and create data interoperability so they can be prepared when all the dimensions of that act kick in, right? And 2026 is when that we start seeing some of those policies come through, and 2027 and 2028 is when these communities are going to face that operational strain, that operational pressure. So from that perspective, I think RHT is a lifeline for these communities to get ready for what's to come. Brittany, do you have any thoughts on that?
No, I agree completely. The only thing that I would add is, I think we have to think about how do these dollars impact the whole continuum.
Yeah.
So as we look at, and I think that's where everyone's head's at, right? We've got to bring technology and we've got to bring infrastructure. We have to do all those things to get them caught up and positioned for the future. But then the other thing, and I've spent many, many hours talking to RHT over the last several months here. The one thing that we absolutely can't forget, and that this money will be for naught, is if we don't have payer partners coming to the table and participating and being part of the solution. So, and again, our biggest challenge in value-based care is the patients are attributed to us. The contracts, the metrics, the total cost of care, our responsibility, and we control less than half of that. And so I really think that sans a lot of collaboration, support, and problem solving, and the providers and payers coming to the table together, we're gonna look back on this 5 years and wish we had done things differently. So that is one of our key strategies in rural health transformation as we position our network, our members, as we're supporting submissions of RFAs. Cibolo is not applying for any of the dollars. We help support our members at the individual and network level. That is a key tenet to everything that we're doing, is how do we engage the payers? How do we help support them to meet their goals and objectives? And then on the other hand, get some more rural relevancy into these negotiations.
As Pranam pointed out, the cuts against the $50 billion are not comparable, but it also presents an opportunity for transformation, because another comparison is we got $36 billion for the meaningful use, and this is 50, right? So from that perspective, there's a lot of opportunity to transform if they're invested wisely. Pranam, I'd love to dive into more of the details of what rural health really should be doing. Like, how should they be approaching things like their data strategy or interoperability, maybe to address what Brittany's talking about, the fact that many of their patients are going to other organizations, or even just connecting care for them. What should they be doing right now, and how should they be approaching these things?
I think the way we come at it in our partnership with Cibolo, John, is to say, what is the guiding principle here, right? If we can get these providers who are constrained for resources and bandwidth, to focus on the right patients at the right time for the right reasons, right? Let's say that's the principle, right? And then we say, okay, to get to that point, where do we begin? Where do we start? And you quickly realize that what we need to do is to convert that longitudinal relationships that these providers have established with their patients into longitudinal data records that transcend all the traditional constraints that they're dealt with. So from that perspective, you look at how can I convert available data into actionable insights, right? So that's kind of like how we came at this. So creating that infrastructure that allows for that interoperability to happen, that allows for that one version of the truth to be made available to all these providers and helping them focus on the patients that matter, defined by value-based contracts, defined by high utilizers, defined by patients that have severe access issues, right? So you create those cohorts and allow this lean care teams to focus on those patients to move the needle. And that's how I think we will very realistically, in a very applied way, get to the point. Now, you can wrap the strategy around with AI, automation, intelligence, but I think at the core of it is to create that infrastructure where data is interoperable and you're able to convert that available data into actionable insights.
Yeah. Brittany, I imagine you agree that the data is the key to all of this, but I'd love to hear also like what AI and automation solutions on top of that data make sense for rural health to really embrace and have that transformation that we talked about.
Oh, I think that there is tons of utility. I think that, you know, our CMO always says the AI is the absolute worst it'll ever be today. Like it just evolves, it's evolving so quickly. And I was having a conversation earlier today about, you know, in healthcare, we typically are relatively slow adopters. It takes a long time to change clinical practice guidelines. It takes a long time to get really meaningful upgrades in infrastructure, technology. It's just very complex. I think that AI has been maybe the exception where it's almost like a necessity to utilize it. And if you don't, I mean, just the efficiency that it garners. One of the examples that I used today was, you know, we've been pushing around the same vital signs cart for 70 years, like doing it the same way. Now we're seeing these wearable devices that check physiological monitoring against your internal baseline, not just what the textbooks say is normal. And then there's AI algorithms that sit over the top so that you're not running down to check on the patient or calling them on the phone if they're, you know, in their home every 10 seconds because of alarm fatigue. And I think that there is utility for AI in every single facet of healthcare. And I don't think it means that it replaces healthcare providers. You can't take the people part out, but there's definitely opportunity. One of the things that Pranam and I have worked on together is contract compliance. So our facilities, a lot of them don't have they're doing a lot of work very manually. Trying to understand how you get paid via contract can be extremely challenging. It's nuanced. You have many contracts, many payers. It's really challenging. And so, like, how can we put AI up against the, you know, what we're getting reimbursed and our contract and help us understand how do we improve our documentation? How do we make sure that we're being accurate? How do we ensure that we're getting paid for the services rendered? And so I don't know, primarily about a year in that we built a contract compliance platform together that we're continually evolving. Every couple of weeks, there's a new rendition coming out. It's getting smarter. The more data we put into it, the more robust it gets.
Yeah, we're about 8 months into it, John. And like Brittany said, it's just been amazing to see the scale at which you can apply these models. Like today we have built a model, we evolved a model that can consume a contract in 25 seconds on an average and parse through millions of payment records to identify revenue opportunities.
Wow.
Let's say on an average, the industry studies say that 3 to 6% of revenue typically is compromised because of contractual non-compliance. Let's say we are able to help these members recoup 50% of that. That, for some of these members, could be the matter of life or death, right? Because they are so financially strained, operating on such thin margins. So this is the power of, how we can apply AI. And the word apply is key, right? For us, AI should be invisible to the members' realization of its value. So what I mean by that is when this contract compliance agent does what it does, what it presents to the user should be a very easy, consumable, actionable experience, right? You can't take the complexity and sophistication of the model and dump it on the user. Definitely not in rural care, right? So we are very cognizant of how we apply this. Patient outreach is another use case where we are applying AI. And I think if you look at in general where healthcare has leveraged AI, documentation, prior auth, I think all of those apply in rural care as well. But what we need to be very cognizant of is the fragility of that community and protecting the sanctity of that longitudinal relationships, which Brittany spoke to. So we are more cautious when we apply for rural communities. And the margin of error is also, you got to be very careful about the fact that these members, they don't have large teams that have a lot of time and energy available to tweak and go back and forth with these solutions, right? So you have this very lean runway to get this right and get it in a way that is non-frictional for them. So some unique challenges, but I think if we can prove it here, if we can apply AI in a rural setting, I think that's the greatest case study or greatest validation of AI in healthcare.
Yeah. Brittany, you mentioned the importance of value-based care in a rural environment, highlighted some of the challenges too. Like, what does it really take to be successful with value-based care? I mean, is it the contracts? Is it the AI? Is it the data? Like, is it everything? Like what does it take to really coordinate and be successful in value-based care? Because in rural health, it is hard, right?
Yeah, I think that, so all of the above. I can tell you one of our most significant challenges today is not provider engagement. It's not willingness to focus on the right things preventatively. It is access to data. And so it is very, very challenging. So the vast majority, over 90% of our members across all of our networks, they don't own their instance of their EMR. So there is a host site that typically, controls and manages that. And nothing, moves very fast in that realm. And then on the payer side as well, we get data from the payers. It's the age-old complexity of reconciling the data. So that what they have from a claim standpoint is reconciled and picking up the right things out of the EMR. And so my hope with rural health transformation is that there's going to be a new level of emphasis on data integrity and governance, and will allow them financially and just with sort of national and state support to get much more coordinated in how we're looking at this. The thing that makes our facilities magic and that I love about them the most is that implementation of new workflows or process changes is pretty low friction. It's easier to get into a smaller facility and bring them centralized care coordination. or provide them a tool. You're not trying to coordinate thousands of people to be trained, and it's relatively controlled. They trust their leadership. They're hungry to provide really good care. It's the giving them the right tools that are accurate to directionally allocate resources.
Yeah. I mean, they already care about their neighbor generally. So
Yeah,
that's
yeah,
better than a lot of organizations where they don't know who they're seeing the patient. But
yeah.
what are some examples of like real world use cases where you're seeing value-based care being successfully implemented, and how did they approach it to make sure that they had success?
Um, just a comment on the previous
Sure.
question, John. I think the fact that rural healthcare is so human-centric in its design makes it a great candidate for value-based care if we
Mm,
can get it right, because you don't have the general approach that I'm going to maximize the number of encounters and touch points to make this viable, right? I don't think rural healthcare operates that way, right? So I think if you want to look at VBC at scale, rural healthcare is a great place to operationalize that. In terms of BBC in general, and this is an interesting story, John. I started the business on the same day that the first batch of ACOs were formed, right? So we've kind of been close witness to the entire evolution of value-based care in this country for the last 14 years. And I'll just give you one stat, just because of by way of work with the ACOs. Back in 2010, there was a projection that um, the total spend by 2025 is going to be $6 trillion, right?
mhm.
So just by way of the ACO movement, there's a validation of the fact that at a macro level, we've reduced the spend by $1 trillion with this whole APM VBC movement. Now, you can look at it different ways and say we could have done more, we could have done it faster. Absolutely. Make all the points that you want. But value-based care has been proven beyond any reasonable doubt in every patient segment. Now, if you look at every reimbursement dollar that flows through the system, 60% of the reimbursement has a value-based modifier built in. Either it's quality, shared savings, however you want to look at it. So VBC at a macro level is proven. And I think there is commitment from all sectors, all constituents. To Brittany's point, I think some of the ground level challenges is what makes it harder to scale. Data interoperability is an example. Data standardization is an example. Um, Scaling care management is not easy because we have a major imbalance in supply and demand, right? So there's a lot of like some of the scaling challenges that we as a ecosystem are dealing with, but there's multiple use cases. So one is ACO. I'll give you another example of a very mid-sized multi-specialty center in New York, one of our other customers that we work with, that just by recalibrating their quality measures using codified data, right? Data that was not raw, but that was codified, we're able to find $240,000 in bonus payment. It's just a very simple example. $240,000 for a $100 million organization may not seem much, but the fact that it required a codification layer on their quality reporting to help them recalibrate their performance and help them realize those additional dollars is a fact that we should all celebrate. So there's many such use cases that are flowing through our world, that are flowing through Cibolo's world on a daily basis. I think what we have to put a collective effort and energy is to scale it to the point where this becomes the norm in the reality and not becomes a use case we talk about.
Interesting. Brittany, where are you seeing value-based care have an impact? Any stories that you could share?
One of our greatest successes, so we've invested obviously in population health platform, centralized care coordination, cost and quality data to inform referrals. We have infrastructure that we bring to the facilities. I would say, really pragmatically, probably where we've seen the best impact around value-based care. So really translating to good quality preventative health care, screening, chronic disease management, has been through extending the care team. And that is, we have a centralized care coordination strategy. Each of those, at each facility that utilizes this, it is tailored based on what the individual facility has for infrastructure. And so keeping the actual provider and care team as the primary individual responsible for care coordination, and us just supporting in the background. We have local phone numbers. We use the script that the providers ask us to use. We prioritize based on the list coming out of the garage. Who should we be focusing on? That has been probably the most impactful strategy that we've deployed.
Amazing. Well, as we wrap up, what does the future of rural healthcare look like, and what needs to be done to make sure that it has a successful future that I think most of us really want, and because we understand the importance of it to those communities. But maybe you can start, Brittany, and then Pranam.
Well, my hope for rural healthcare is that as we kind of round out this 5-year trajectory with RHT, that there is cleaner data that provides more clarity, that our relationships with payers continue to evolve into these partnerships that we're seeing them moving in the right direction. But I think that we got to work quick and deliberately. And I think that it means that we have to look at, how we define access and service, not just around number of miles driven, but around true cost and quality, and building strong referral partners with our tertiary and quaternary partners. I think it's sounds easy. There'll be challenges, but that's the journey that we've been on, and that's the vision that Cibolo sees and what we're asked by our members to try and tackle. And so that's my hope.
Awesome. Pranam, what would you add?
No, I think Brittany said it all. And from my perspective, I think the intent is to ensure that I look at it as we are on a clock, because RSU dollars are beginning to come in, and the realities of the Medicaid cuts are also around the corner. So we are on a clock. I think if we work together as a community to create a coordinated system of care that will allow for virtualization, that will allow for a common infrastructure, and more importantly, this is where I truly respect and appreciate the work that Cibolo does, which is enabling a layer of shared services, right? That will allow for these members to sustain and thrive together, not as independent, separate entities. And even simple thing that I hope that no patient in a rural community has to commute for 60 minutes to see their provider, or no patient has to wait for months to see a specialist, right? And if you can bring down the per capita spend by 1/3. So these are some of the quantifiable metrics that we as a community can target and use this RHT dollars and opportunity to get there together quickly with the right cultural shift. I think that's my biggest hope, and I think it's a very practical reality given the work that we've been doing with partners like Cibolo.
Love it. Well, rural health is important, I think, to our healthcare system, and I appreciate all the hard work you all are doing to make it more effective and to make the models work for those organizations, because I think that's core to it, making sure the data is there to make the models work as well. So thanks to both of you for shining some insights and perspectives into what's happening in rural healthcare and value-based care in particular. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcast applications. Thanks, Pranam. Thanks, Brittany.
Thank you, John.
Thank
Appreciate you
you.
having us. Thank you. Thanks, Brittany.